Okay, good. Good morning.
Yeah.
Hi, I'm Debbie Thompson, President of Strategy Solutions, and we're gathered here today to talk not so much about some details related to the measurement and evaluation process for the Community Health Needs Assessment, even though I'm going to touch on that a little bit. We're actually here today to talk more about the concept of community benefit and appropriately measuring the community benefit that we're doing along with the implementation strategies for the Community Health Needs Assessment. So the purpose of this particular workshop is to help you look at your hospital and health system and how you are measuring community benefit as well as your outcomes and impacts related to the AAA, lowering cost, improving quality, and improving health status. Because what we've been finding in a number of our other hospital clients is that community benefit, while a lot of people equate community health needs assessment implementation strategies with community benefit, because a lot of the outreach you're doing and the programs that you offer free of charge as a community benefit, that most of the hospitals are not capturing all of the community benefit activity and accurately reporting to the community everything that you could be reporting in terms of the contribution to the community. So I really want to talk specifically about the community benefit requirements and what most of us don't know about community benefit, even if we have someone, who's dutifully working on the Subsidized software and helping us to try to capture it. What we found is there's a lot of that we don't know. And we also want to provide a little reminder for you how to continue to think about integrating your marketing, revenue generation, and population health improvement outcomes and impact through the community benefit process, because that's also really important. And then really the purpose of today was really to help you identify some strategies to help you improve your community benefit reporting as well as your outcomes and impact measurement system. So we're hoping to do both things during our time together here over the next 30 minutes or so. And I want to also perhaps suggest that we consider as part of our evaluation process moving forward to think about maybe looking at auditing the community, how much are we actually capturing our community benefit sort of along with our outcomes. Because right now community benefit reporting is separate from outcomes, even though we could be looking at some of it together. But we wanted to raise some questions to help you assess your knowledge of your activities related to community benefit, educate you a little bit about some of the guidelines and how the Accountable Care Act is evolving, even though the elements from what we can tell, even if the Affordable Care Act as we know it gets repealed, the components that are supporting value-based purchasing and the evolution to population health are going to continue no matter what. Although what I'm suggesting to you that you may want to consider is that while I'm there this year because I usually come down for a couple of days to help with the evaluation process and to, start looking at, here's our data from this year. I'm actually suggesting that as part of that audit process, we include some interviews with leaders to help those of you who are in the room today, to help you identify community benefit practices that you may not be counting or should be quantifying as part of this. So that's actually my suggestion to enhance the evaluation process this year, is to help look at, are we capturing all of our community benefit that we should be capturing along with our outcomes and impact measurement? And then maybe looking at, how do we, where do we want to be in terms of, our not only our community benefit, but, our next steps to continuing to impact the health of the population, and then as I said, I will be recommending some strategies to help you better quantify your community benefit today, as well as your outcomes and impacts. But what I'm suggesting is that you consider we enhance the evaluation process this year to include some of these community benefit audit principles, because I'm guessing that there's some of you in the room that may not, like me, we may not know what we don't know about community benefit. So what is community benefit? They're programs and services designed to improve health in communities and increase access to health care. Now, what a lot of you may not know is that what we now know as community benefit reporting actually came from the Catholic Health Association of the United States. And the evolution of community benefits started back under the Hill-Burton Act in 1946 and actually evolved to include charity care as part of community benefit in 1965, and then was amended related to how we track charity care in 1975. But in 2008 and in 2009, when the new Schedule H came out, the IRS decided to actually follow the Catholic Health Association's community benefit reporting standard because they liked what they were doing. So in other words, the feds were like, these Catholic hospital people over here are doing a really great job of capturing and reporting on community benefit. We ought to force everybody to do it this way because it's the best practice. So they actually made it regulation for everybody to follow that format. And it's just sort of evolved from there. And they actually sort of added to it moving forward with the Affordable Care Act and the CHNA, or the Community Health Needs Assessment Guideline, that came out in 2013. Now, the letter of the law related to community health needs assessment, as you all know, is that we do a needs assessment every 3 years. You've got to identify these chronic disease conditions. But the thing to remember is there's lots of guidelines we have to follow, but the spirit of the law is to create a population-based planning and healthcare delivery system and to really manage the health of the population to lower healthcare costs and improve quality and improve health status. And I have a slide and a couple slides. It's actually slide 11 in this deck that says the thing to remember about this is that while all community benefit activities need to connect to a community need in some way, not all of your implementation strategies need to be community benefit. In other words, like we're measuring and evaluating with the cancer program, there are community benefit aspects to the outreach and screening and education that happens in your organization related to the cancer program. But there's, and you know, those, hopefully all of those activities that are not funded or aren't reimbursable are all counted as part of community benefit. But we can count other intervention strategies like as, you know, heart care or education programs, or even like diabetes management programs that we may get reimbursed for. We can count those as implementation strategies. Now here's a question. If I were in the room, if I were in the room with y'all, I'd have the option finder there, and I would be asking you to answer this question on the keypads. But I'd like those of you who are sitting in the room there to give me a sense of, to what your answer to this question, to what extent do you feel you're capturing all of the community benefit activities in all of the categories that could be counted as community benefit? Would your guess be that you're collecting less than 25%, that you're collecting 25 to less than 50%, 50 to less than 75, 75 to less than 90? Or do you think you're capturing all of the things of community benefit that you could or should be capturing? Oh, I'd say full.
I'd say 25 to 50.
Seriously?
What do you think? Don't you think, Selena? Because people aren't reporting, and there are things that we, you know, that I'm learning along the way that we can count as community benefits. So I've got to do a better job of education, but, and Selena can help because she.
Well, we've got a lot of folks that report every single month, but it's things like support groups and, all that kind of stuff that I'm not really sure if we can.
And there are some.
So we have some good, some folks that are really good at reporting. Right.
What, Debbie?
We have some groups that are really good at reporting, and they report everything that they can think of, and other folks that don't report anything, right?
Right.
And what we've found, what Kathy and I have found in actually talking to individual departments, is that even the ones who are reporting regularly aren't necessarily reporting all of everything that they're doing. And that's part of the reason why we're trying to educate folks about this and connect the dots with our evaluation efforts, because making sure that your hospital and health system gets credit in the community for all the good work that you're doing and the community benefit that you have to offer, I think is an important part of the measurement and evaluation process, which is why we're bringing it up. Now, again, if I had the option finder, I would ask all of you to say, how would you rate your current knowledge of the community benefit requirements related to the various categories? I love option number 3 here. I know enough to be dangerous and not enough to be effective.
Wait a second. I'm having another little thingy, my Bobby. Okay. Can you repeat that? It went down for a second.
Okay. No, my question for you all in the room is, how would you rate your current knowledge of community benefit requirement related to the various categories that you could capture community benefit? And this is a be honest.
I've read, a fair amount, and I understand enough to get by, but I could certainly use more education. As a whole, I don't think anybody really understands it at all, to be honest.
1.5.
Yeah. Right. I agree with Selena.
Right. And most of us, if we know anything at all, are kind of in the I know enough to be dangerous but not enough to be effective category. But again, that's why we're doing this webinar, to raise your awareness of some of these things, because what we found is that most people are not aware of it. And even if we are aware of it, that we're not necessarily tracking all of what we could be tracking. And one of the things that we want to share with you are some ideas that we found that what I call reduce the administrative burden around capturing the community benefit activities by looking at who owns the majority of them and thinking about them in a global way rather than tracking hour by hour. So as we go into the, kind of what's the checklist of things that we can do, what is included there. Remember this, as I said earlier, community health improvement strategies don't have to be community benefit, but all community benefit strategies should be tied to community needs in some way. So with that as the backdrop, here are the various community benefit categories. There's 9 of them, and I'm going to go through each of them and give you a few sort of checkpoints to think about. And one of the things that we're putting together for one of our other clients is kind of a summarized version of this, kind of a one-pager that's like a check sheet for individual department managers to think about, do I have this going on in my department? Because while some of these things, like financial assistance and means-tested public programs, are things that are usually reported out of the finance department and included in the, in the 990 and the community benefit reporting, these items 3 through 9, that you may have things going on in your department that you just had no idea that it could be counted as community benefit. And that's why we're here to talk about it. So financial assistance, this includes all of your charity care, reported in cost, not charges. Most hospitals, because the finance department calculates this, this is a good number. It's pretty reliable. The second one is means-tested public programs. These are things like Medicaid shortfalls, local and state government programs for low-income people, again, calculated by the finance department, and usually it's a pretty good number that's reported. But here's where we start to look at things where we're not sure we're counting everything, like community health improvement services and programs. These are any type of activities carried out to improve community health. And what we found is that a lot of departments will do outreach programs, they'll do screening programs, they'll do different type of support programs for community health. Like, for example, emergency departments in some hospitals actually give different kinds of supply kits to ambulance companies as part of the, sort of emergency management system. And the hospital's paying for that and not counting it as a community benefit. So activities not counted as community benefit are those available only to individuals affiliated with the organization. So like if you're doing like a blood pressure screening for your employees only, you couldn't count that as community benefit. But if you're doing any type of program for the community, even if you're doing it for a nominal fee, like a $5 payment for the flu shot, the difference between the cost of the flu shots to deliver it, including all of the staff time, minus the $5 fee, the difference there could be counted as community benefit. Some people don't count that.
I got a question.
Yeah.
This is Brendan. I don't know if it falls under this title, but could we not count? I know Carrie and I serve on the board for True Care, which is a community-based clinic. Could we not count hours at the meeting?
Yes, you can. You can count all of those hours as community benefit. And the other thing that we found is that there'll be a clinician doing a community health education outreach program. And the outreach program actually is 2 hours, okay? So we're doing a 2-hour program in the community. What some people do is they count only the 2 hours that they go out in the community. They're not counting the 10 hours of preparation that it took them to get ready to go out into the community, nor are they counting the 10 hours that they spent on the phone for the next 2 weeks because people called them to ask questions after the event.
And what about
all
the travel to the event?
Correct. All of that is countable.
Well, we actually, the forms that I've created at the bottom of the form, it actually has a section to capture any supplies or mileage or any of that kind of stuff. So they can count, syringes, needles, cotton balls, whatever they take with them.
Excellent. So you're a step ahead. You're a step ahead of most people, okay? The activities can include the education and outreach, clinical community-based services where there's no patient billing, healthcare support service, transportation, any, violence prevention activities, any type of activity that, again, provides some type of education. Here's another place where the guidelines offer a lot of community benefit support and leeway that a lot of people aren't counting. Health professions education includes any type of program, any type of continuing education program for physicians, interns, residents, medical students, people that are interested in becoming doctors and nurses, okay, or any type of precepting. And what we found in this area is that a lot of organizations are underreporting the time that clinicians are spending precepting students. Like, for example, speech therapists, for example. A clinician that is precepting a speech therapy student has to actually spend an enormous amount of time with them as part of that education and training process. And the time that they spend precepting is actually a community benefit. If you have a student shadowing you or you're doing tours of the hospital in order to help support getting into health professions, all of that time counts as community benefit. And if you have staff in your department, like we found in one hospital that they have a volunteer program, but as part of their volunteer program, probably half of the students that were coming in were actually students that were getting work experience as part of their curriculum for a particular degree. That's not, and they're actually, that activity is actually workforce development. It's not just volunteer activities that benefit the hospital or the hospital programs. Those kinds you could tease out some of that time because it's health professions education, and really looking at what component of that is part of what you're doing. A lot of hospitals don't appropriately record all of that. Subsidized health services.
Hey, can I go back?
Sure.
Is it like continuing, like CMEs for physicians? Do we count that, Selena?
I've never seen anything before.
Because we did provide, right, Brenda, provide, well, but I think it's like the certified, we had to go through a program too, where instead of just the meetings, it's like a educational program where they get continuing education hours. Yeah,
correct.
So,
and here's the thing, if you are offering that program to the community so that clinicians outside of your doctors, your medical staff, and your employees are benefiting from that training, that's considered a community benefit.
Okay.
Okay, so you can count that.
One question I have about the nursing students. Now, we have nursing students in our nursing homes and all over the nursing floors, pharmacy, and, I mean, all those areas. And we have folks that turn those in, as hundreds of hours a month, and we're counting that.
Yes, you should.
Okay.
Yes, you should. And it's good to hear that you have folks that are doing that, because we've found organizations that in some cases aren't doing it at all, or if they're doing it, they're underreporting it. Like, for example, what we've seen in some places is that the nursing floor, if they've got students on the floor, then the nursing floor might count it, but those nurses might also spend time in pharmacy and physical therapy, and those two departments aren't counting for those same students.
Okay.
Okay, so if you may have people touching multiple departments, but not everyone is necessarily reporting all of that activity.
Okay.
So again, our job here today is to stimulate your thinking about what you might be missing.
Okay.
And think about how to include it, because there are many that underreport that. Subsidized health care services. It could be any type of patient care program that is provided, even if it's at a financial loss. Services that meet a community need, and if no longer would be that weren't offered, wouldn't be available in the area. And it could include certain types of inpatient or outpatient programs, if those programs are truly offered in a loss and not just losing money because they're being run inefficiently.
Right.
It does exclude ancillary services that support inpatient and ambulatory programs. And you can't report a service if it's not meeting an identified community health need, if it's just inefficient, or there's volatile reimbursement, or you're not getting people to come. You're losing money because your program isn't being fully utilized because there's other competitors. So you have to be careful about, what do you try to count in terms of a subsidized health services. But you have a pretty large clinic operation that I'm guessing you're counting as community benefit.
What do you mean? Like our community service clinic or the true care
Correct.
clinic? Right.
Both.
We're not.
Not, and that's a huge, and plus the pharmacy there is subsidizing a lot of the medications.
So, I guess that we report that like on the CHNA, but our,
Yeah, 'cause I thought that
I
was
thought
going through
that
our
was,
financial
that's going
assistance
to
report.
financial.
It's not coming
Yeah,
through
yeah, we
by
already-
Subsidized.
yeah.
okay.
Part of that money.
But that's under the 990, but, so we can, would that be double counting it if we put it into the Subsidized system, but it's already being counted elsewhere?
If it is being counted elsewhere, you don't want to double count. But if it's,
Okay.
but again, the question is just double check to make sure that it's being fully,
Okay, yeah,
fully
okay,
counted.
Imagine.
Okay?
okay.
Including the cost associated with the, sometimes we found that people, they may cover the cost of the clinics, but they're not looking at the cost of the ancillary services that were provided along with the clinic services that were all provided free of charge. So something to think about. This has become one of my favorite topics in this whole community benefit is this idea of research, because a lot of things actually can be counted as research that we don't think about as research. So it could be anything that's engaging in medical or healthcare research where the organization is concerned about the long-term welfare of the community. So it could include activities to increase knowledge, natural processes of principles affecting health or illness, health outcomes, studies related to changes in the healthcare delivery system. So any of those can count as research, even if they're not being overseen by a research department.
Okay. Hey, let me ask you something. So one of our oncologists is getting ready to start some clinical trials, correct?
Staff member that's devoted to research.
And that is, as you recall, the medical offices are separate from the hospital. So, and if it's run through his office and not the hospital, it's the health system. Can that be counted, or do we need to somehow try to finagle it where it's run through the hospital so we can count it?
Well, if he's paid by the physician practice, you couldn't count all of his time and the resources that his practice are putting into it, but you could count all the time that any hospital staff members are spending to support the research process, or any of the any of the costs associated with participating in the research. Like, say for example, to participate in the research, you have to get consent. So the time that somebody would, if it's a hospital staff person talking to the patient about getting consent to be involved in the research process, all of that time counts. If the patients need to have an extra test.
So, wait, Wanda was saying something right then.
I'm not sure if the person working with that program with him is a hospital employee or if she's fallen under his practice as a staff. So we need to establish that and determine if, there's some hours there to be counted.
I think.
Right. But the other thing to think about is any type of research work. Like, Wanda, I know that you've presented poster presentations at different conferences based on the work that you're doing.
Poster presentations.
Oh, yeah, see, I didn't count any. I do a lot of education stuff, and myself, that I've never counted any of that, so.
And you could, okay?
Yeah, we'll go back and try to capture some of those hours.
Okay. Because some of it is actually, if you have clinicians working on a research project so that they could publish something at a state or national conference or write into a trade journal, all of that time, whether it's educating, some of it can be counted as continuing education for the community. Any time that there is an audience outside of your employee population that would benefit from the time and learning that clinicians spend doing it, the research time to write and prepare the report would all be considered research, and the time involved with presenting at a national conference or doing a poster presentation, all that prep and all that time could also be counted.
Okay, so
A lot of people miss
Okay,
that.
Brenda has
A lot of people miss that nuance.
Okay, Brenda has a question.
but it really for you, I'm
For
writing
me,
down,
what?
because Ralph Dim is preparing to present at the premier national conference in June. So that's outside of our audit.
Okay.
And plus, like I said, he's working with a new research program with Dr. Harlander that they're going to start doing. Now, what time frame is this from? Is it calendar year?
It's from July 1st of last year to June 30th of this year.
So you would be able to get.
Yeah, we can go back.
Oh, that thing I did was in June last year, so, but Lori did something in the fall.
Okay.
Or, I can't remember.
But we can check.
Maybe not, we'll check. Well, I've got a question. I'm serving on a statewide leadership board that's planning a survivorship education piece, so I could probably count those hours too?
Yes, you can.
Okay. Right.
Yep, all the time you spend, planning for a state conference or a national conference, that preparatory time, the time you spend on a community board that is involved in education, that's all considered continuing education. So the next category is cash and in-kind contributions for community benefit. They can count if you're making some type of donation to another organization to support community benefits provided by others. Like, say, for example, the hospital actually invests in, X amount of dollars for the, let's say, the American Heart Association chapter to run a outreach program. That would be considered community benefit. It could also include other cash donations and other donations such as the cost of meeting room supplies or equipment, parking vouchers for a program. Those types of things can be considered community benefit. And cash can be allowed if it's restricted to a certain activity that relates to a particular program or outcome. You also have, there's a couple of exclusions related to cash and in-kind contributions. They shouldn't be reported if they're unrestricted or for things other than community benefit. It can't be a payment in lieu of taxes, those kinds of pilots that hospitals sometimes have with local municipalities. That doesn't count. The contribution has to be intended to address a community health need.
Can I ask a question on this? So,
Sure.
For example, last month, the Heart of West Georgia had the golf tournament, but those contributions were fundraisers, so you don't, and so how do those come in?
That goes to that organization to provide services in this community.
So just so you know, and I don't think I've really discussed this with Selena, but with WellStar, now that we've been a part of them, for anything that's a sponsorship, the requesting agency has to submit a whole thing to WellStar, and I can get that information so we can put it on ours. So it's captured everything that we have, given as a donation toward a walk or a golf tournament or whatever. That is captured at the corporate level, and this is my reminder that I need to get that information and give it to Selena, because we have that. But all that counts.
Right. But what doesn't count is volunteer efforts. So if a staff member is doing something as a volunteer in the community or engaged in an activity on their own time, that does not count. The exception to that is when, but if you are volunteering, like to be on a statewide board or something, and that's related to continuing medical education, and you're doing it on paid staff time, those kinds of things count if they're done on paid staff time.
Selena just pointed something out, which is also
I was asking, and I thought I had read this somewhere, that if a salaried employee has been asked by the hospital to do something after hours as a community benefit, we can count that as their time.
If
Even
they're
though
correct.
They're not really volunteering, but they sort of are.
They're doing it on behalf of the hospital, and they're salaried, so that they're paid, then that can be considered, that can count, correct?
Yes, that's my understanding.
Okay.
Mm-hmm. Right. So the next category is all of the activities related to community benefit operations, which include all of the costs associated with planning and operating any type of community benefit programs, which can include the cost of staff, the community health needs assessment itself, the evaluation activities, the software that supports community benefit, the cost of the software, the hospital's cost incurred in writing grants or raising funds specifically for community benefit activities and programs. This is one of those that we don't think to include in community benefit. If you have a staff member who's actually writing a grant to fund a program, that grant writing time could actually be counted as community benefit. And dues and program expenses for the hospital that specifically support the community benefit program, such as ACHI. So if, Jan, did you count all of the costs that, the last time you went to an ACHI conference?
No, because I hadn't been in a long time. I didn't know I could count it then. But there is something I just went with to GHA, so I'll count that.
Right.
It was
okay.
Okay, go ahead. I'm sorry.
Okay. Any programs that address the underlying causes of health problems that improve health status and quality of life, any type of programs that focus on, things like poverty, homelessness, environmental hazards, these all are considered community building activities. So like the work that you do with Troop Cares, all of that counts. The work that, Jerry belongs to Troop Strategic Planning, that group. Do you think about his time involved in that group? And the sort of the byproducts of the different folks that might get involved in activities on his behalf, that would all be considered part of community building activities. And anything that would enhance community assets by offering the expertise and the resources of the healthcare organization can all be considered part of community building, community benefit activities.
Can you give an example of that?
Well, let's say, do you have anyone who sits on the board of the United Way, for example, who is involved in, helping to shape new programming to help people get out of poverty? That would be an example of community building activities. It can also include like physical improvements in housing, economic development, community support, environmental improvements. I know hospital system who actually made some investments in the neighborhood surrounding the hospital to a nonprofit organization that was helping to improve the housing stock and, do like community gardens. That would be considered a community benefit. And they had people that were involved, like the hospital that I used to work at. I actually helped to establish a nonprofit community development corporation in one of the local neighborhoods. All of that work would be considered community building activities and would be considered a community benefit. So now that we've reviewed the guidelines, how would you describe your department's current practice? Do you feel that your department's reporting none of what you should be reporting, that your department's reporting some, that it's reporting most, or it's reporting all of the things that you should be reporting?
We've got some departments that are doing none. We've got some departments that are doing some, but nobody that's doing most or all.
Yeah.
There you go.
There you go.
Right. Well, and that's usually the way it happens, okay? And what are some of the things, there's some of the things that we've just talked about in this last 40 minutes that could help improve your reporting if you captured it?
I think we can, I can work with Selena to come up with a list or, and based on some of the things that have been said in this meeting and things that we can look at across the board, just to kind of send out a list of saying, hey, these things count and you need to.
I've got about 5 things on my list right here that I need to go back and report that I've not. We've just spent some time planning on a research project we're doing with Georgia Corps on prostate cancer. We've already spent a few hours in the planning process of that, and
you had that.
And I had an internship that was part of that. I've had an intern with me for 2 semesters that it never occurred to me to.
Don't forget to count my hours too. You need to count.
You count your hours.
Do we do one? Don't you do 2 kids?
Well,
4.
It was for the
She's a
brain
mental health counseling student. She was really under Brenda, but she spent the time with me.
Sometime with my people too.
We just count her total hours.
That's what I'm
that
thinking.
One of you, if it's total hours, then one of you needs to report.
Yeah, that's what
You've got some two different departments.
No,
It'll
it'll be total hours on her. That's what we'll do.
That's fine.
Okay.
Well, and one of the things that we found out in the process of learning more about community benefit is if you have, and this strategy can help you reduce some of the administrative burden of tracking individual hours. If you have positions within your health system that do community benefit work all the time, like, for example, we found like the volunteer coordinators in one hospital, actually part of their job on an ongoing basis was screening students and placing students that were doing preceptorships and internships that were related to their learning. So we actually had them do a time study to figure out what percentage of their time was actually supporting student learning versus regular volunteerism. So if you could, by doing a short-term time study, like say over the course of 3 weeks, if you can say this job, 20% of this job is community benefit activities because, and you have a time study to back that up, that you could justify a formula of applying a certain percentage of a job versus, forcing Mary Smith to count her hours. How many hours a week is she actually processing students forever? Okay, it's easier to, if you have a job where a portion of it is defensible and it can be proven that it's community benefit, it's easier for you to track it's based on a portion of a person's job versus forcing that person to count hours for everything that they're doing. And that is a good strategy to improve the reporting process and decrease the administrative burden for people, although it would be a little bit of extra work up front because they'd have to figure out, well, what percentage of the job is actually community benefit. But
that might be a goal for FY18.
Right.
Something that we need
Well,
to be thinking about
No, I don't
Right,
think
it
so.
could be.
Have any one
Right.
person.
Yeah.
Can I backtrack
Right.
and ask one more questions about
Sure.
the registries that we participate in? At one point, we were counting them. That's the National Cardiovascular Disease Registries,
Mm-hmm.
but we quit counting them. And I am trying to remember why we decided they had to come off. But we did decide, it was in a meeting we were like this or something, and we decided they came off. But listen to it. Are you familiar with
the
those
argument?
registries?
I mean, the argument that we typically hear is if it's part of the cost of doing business, you can't count it. But if you're doing extra things over and above the cost of doing business, and a registry is a good example of that, because like in one hospital that we worked with, the cancer registrar, the cancer registrar's work on a daily basis is not community benefit because it's part of the cost of doing business. You have to be part of that registry. Now, what we also found out was that the registrar was also doing a whole bunch of reports for people outside of the hospital that were calling and asking for a report from the cancer registry on this, that, or the other thing. that time involved doing reporting for people outside of the organization that's not part of the cost of doing business could be considered a community benefit.
We use all of the information really internally. We work with the EMS system and we collaborate, but they come and are part of the meetings here, and that would be part of our business anyway. Okay.
But we do count that as,
you can't count it.
but we've counted that with our community, with our CHNA evaluation, not for Subsidized.
Okay, all right. Just wanted to make sure again, just in case.
Right. So, yeah, it's important to recognize, that, some things you can't count as community benefit, but they're important implementation strategies from the needs assessment. That's fine, okay? But if you are missing some of the community benefit counting related to the, you're underreporting some of your community benefit, especially the ones that are related to the needs assessment intervention strategies, okay? Those things that are part of the hospital's commitment to improving community health and the goals and objectives that were developed based on the community needs. You want to make sure you're capturing all of those, even if you're missing some of the other, which is, again, why we wanted to bring this up as something to think about. So, where do we go from here? Here's something to consider as part of our upcoming evaluation process. Do we want to include perhaps, while I'm there, some interviews with selected leaders, looking at your policies and approaches for community benefit aligned with the community health needs assessment, and maybe try to identify some strategies of where things may be missing, and then, come up with an action plan to help improve the practice in reporting, because we found that, again, and we've sort of learned this kind of as a byproduct of the work that we were doing in community health needs assessment, but, we want you to make sure that you're taking credit for everything that you are doing in the community, and, as long as we're looking at the outcomes and impact numbers, we could be questioning, have we captured everything from the community benefit perspective along with that? And that may be worth doing as part of our upcoming evaluation.
Okay.
Jan,
Uh-huh.
can you clarify, is finance netting down that financial assistance number? Because I think I saw on that first or second slide under financial assistance about not charges, but rather costs. And I know the adjustment dollars are actual charges. So are they netting down to cost? Isn't that what we're supposed to be doing instead of charges?
They should be calculated at cost.
I think that, because if you're going by the adjustment log, which is normally what is fed to you, and I think about that $15.5 million in uncompensated care, that's not cost. That's actual charges.
Okay.
So we may need to look into that.
Okay. And do we need to get,
The finance has to apply some type of formula to it
okay.
to extract costs from that number.
Can I, because that's not, I'm not good at that, can I set up a meeting for us to meet with Hazen? Okay. Okay. Hold on, I'm making a note of that.
I don't know how that impacts.
Okay. What else, Debbie?
That's all I have.
Okay. So there are a couple of things that I wanted to talk with you offline about. Do you have any time this afternoon that we can talk about 10 minutes?
Oh, sure. Hang on. Let me stop the recording of this.
Okay.